Hello guys, my name is Hasan Altahoo and today I'm going to present my research, which is a clinical audit on the management of patients with acute ST elevation and myocardial infarction. So just a quick introduction about myself. I went to RCSI in Bahrain and I've done my internship as well in Bahrain. Then I've worked in the Middle East Hospital and now I'm in the University Hospitals of Derby and Burton, which is in the United Kingdom. Ischemic heart disease is the leading cause of death in Bahrain, comprising 13.4% of all deaths. Of course, it's very important to understand the pathology of atherosclerosis, which is seen in patients predisposed to the condition by risk factors such as diabetes, male gender, and family history as well. So this leads to the formation of plaques, just like the one seen here in the picture, and these lead to reduced perfusion of cardiac tissues, and in turn these plaques right here could rupture, leading to occlusion of the artery, which causes myocardial infarction or cardiac tissue death. So when a complete occlusion of a coronary artery takes place, it leads to a transmural myocardial infarction, leading to a clinical ST elevated myocardial infarction. This brings us to the management. And the aim of the management usually is to quickly restore the coronary artery blood flow as soon as possible. So we have two main methods. The first one being percutaneous intervention, which is PCI, or fibrinolysis. So PCI is done through balloon stenting by putting a stent such as this one through the artery, inflating the balloon and improving the blood flow, and then keeping a stent so that blood flow is enhanced after the procedure as well. In comparison to fibrinolysis, which is about giving LTPase, TPA, such medical treatment in order to dissolve the blood clot and improve blood flow. Of course, studies have shown that PCI is superior to fibrinolysis, provided, of course, that time delay is not excessive. So here we understand the importance of time in the treatment of ST elevation MI. Which brings us to our aim, which is to look at the management of acute STEMI in recent clinical practice at our hospital, BDF Hospital, and identify possible grounds for improvement. So this is a standard-based clinical audit, which means that we'll be comparing our clinical practice to international and local guidelines. And the guidelines we used are NICE guidelines and our local standards, which have been adopted from the American Heart Association. So we came about our study by including adult cases who are diagnosed with STEMI between the 1st of January 2016 and the 1st of January 2017. And we've excluded those with fibrinolysis that came from other hospitals. The data we collected are patient information, details of the PCI treatment itself. Then we got access to patient files and analyzed the data in Excel. After which we went to recommend quality improvement strategies after the study, of course. So the results section is divided to three parts. Briefly, we're going to talk about patient data, and then we'll talk about the main points in acute management: door to balloon time, arterial route, and thrombus aspiration. And then we'll come to compare secondary prevention as well to international standards through discussing medical management and lifestyle modification. So, this study had 277 patients, most of which were males, and of course, most of which were referrals from other hospitals, because our hospital is the main cardiac center in the country. So, let's talk about the acute management of STEMI. The NICE guidelines have provided us with very clear recommendations on the treatment of ST elevation MI. But for the purpose of the study, we'll be looking at those coming in the emergency within 12 hours, and we'll be considering PCI as the main reperfusion method, and then we'll be assessing and comparing to international local guidelines with regards to route of entry, thrombus aspiration, and door to balloon time. Of course, the NICE guidelines recommend that radial artery is used and thrombus aspiration to be considered and door to balloon time to be less than 90 minutes. So what is door to balloon time? Door to balloon time is the time at which the patient arrives to the time at which the balloon is inflated, meaning the PCI has started. So this is just to show that time is very critical and we have to minimize it as much as possible. So our local hospital guideline says that primary PCI is to be given for patients presenting within 12 hours, provided that door-to-balloon time is less than 90 minutes. In our facility, the mean door-to-balloon time is 62 minutes, which is compliant with this standard or recommendation. And we can see here in this graph that we have the number of cases of ST elevated MI presenting distributed among the door-to-balloon times. So if you look at the graph here, this is the line of the 90-minute threshold. So all of these cases are compliant, which are a total of 93 cases out of 115, getting us a good percentage of compliance of 80.9%. We further decided to evaluate door-to-balloon time because we've noted that most cases that came with door-to-balloon time more than 90 minutes, meaning not meeting the recommended door-to-balloon time by our local guideline, were patients who came outside of working hours, which are on call hours. If you notice the graph, these are the highest number of cases presenting, and they presented mostly in on-call hours, which are outside the working hours from 7 a.m. to 2 p.m. And because the p-value is less than 0.05, we can see that these calculations are pretty much statistically significant. The mean door-to-balloon time during on-call hours is 99 minutes, which exceeds the recommended timing in our local standard. So this is something to be discussed later in improvement strategies and recommendations as well. With regards to thrombus aspiration, only 36% of cases were considered for thrombus aspiration, and we'll be discussing the reasons for that later on. NICE guidelines also recommend radial artery access in preference to femoral, and we can see in the graph here that 153 patients out of 197 were compliant with this particular recommendation. So there is pretty good compliance with NICE guidelines regarding arterial access as well. Our last part of results is comparing the secondary prevention of STEMI to international guidelines. So the NICE guidelines recommend that all patients should be on antiplatelet therapy, lifelong aspirin, clopidogrel for less than 10 months, statins, beta blockers, and ACE inhibitors. And we can see that with regard to medical treatment in secondary prevention, most of our patients were treated in consistence with the NICE guidelines, and we were very much compliant with a total of 76% compliance, which is really good. The second part of secondary prevention is lifestyle modification. We notice here that the NICE guidelines suggest the need to enhance physical activity in patients that are diagnosed with STEMI, give dietary advice, in particular Mediterranean diet, decrease alcohol intake, and of course smoking cessation. With regards to lifestyle modification, we see that our total adherence to NICE guidelines here is very low in comparison, of course, to medical treatment. So there's a lot of quality improvement to be done here as well. So coming to the discussion, I think it's very relevant to talk about the compliance to international and local guidelines in general in our study. So with regards to acute management, there is pretty much high and adequate compliance to guidelines. However, in secondary prevention, only medical treatment were satisfactory in compliance with guidelines, and lifestyle modification were not compliant, and we had a very low percentage that we need to address. The Gulf Coast Registry is a study that takes into consideration PCI done in centers throughout the Middle East. So we're going to look at our results and compare them to this study. The Gulf Coast Registry says that 10% of all acute STEMI patients were given PCI in Bahrain. This contradicts our study because in our study and our facility, 71 of patients with STEMI have undergone PCI. However, the door-to-balloon time in Bahrain was 81%, compliant with the local recommendation, which is that door-to-balloon time should be done under 90 minutes in the Gulf Coast Registry, and this is also consistent with our percentage that we came up in our study. So we can see that in comparison to the UAE, Kuwait, and Oman, we have a much better compliance to local recommendations. With regards to thrombus aspiration, we've noticed that only 36% of patients underwent aspiration, and this is actually considered justifiable because when we looked at recent studies, they showed that no improvement was associated with thrombus aspiration during PCI, and in fact some studies showed that it was associated with complications such as stroke. So that's why the decrease in compliance to this particular NICE recommendation is justifiable. So coming to our recommendations, because we've noticed that there is in compliance with guidelines only in on-call hours, we suggest a 24/7 STEMI program that is available during working and on-call hours to address cases coming to the emergency with ST elevation MI. Also, because time is very critical, it's very important to educate high-risk patients to get sufficient education on symptoms, signs of MI, and advice to seek medical help immediately. Last but not least, because we've noticed that there are so many deficiencies in secondary prevention, in particular lifestyle guidance after MI diagnosis, it's very viable to consider a rehabilitation center that focuses mainly on applying and implementing secondary prevention and follow-up. In conclusion, we had statistically significant results showing that our facility has good quality clinical care regarding primary treatment of STEMI. As you can see that our mean door-to-balloon time was 62 minutes in compliance with the standard 90 minutes door-to-balloon time. However, on call hours, a lot of improvement need to be done, and of course there's an urgent need for improvement in follow-up and secondary prevention, in particular lifestyle modification in STEMI patients. Thank you so much, and I hope I'll be seeing you in future conferences.